I'm going to begin so that we give Miranda as much time as possible. Welcome everyone to the session of World IA Day 2022 called Championing UX in Healthcare. This session is being recorded, but the audience is not. So we are excited to have you join today's webinar with Miranda Sawyer. Miranda is a UX architect at a healthcare startup, BAMF Health, which is a cancer clinic that is focused on intelligence-based precision medicine through artificial intelligence-enabled molecular imaging and theranostics. Miranda has several years of experience in healthcare design, as well as content management systems for global platforms in both businesses to business and business to consumer, which probably why she's interested in information architecture. So she has created design operations for a global agile and continuous integration, continuous deployment ordering platform. Please make sense of that for us, Miranda. And she's also a mentor for the ADP list. Welcome, Miranda, and thank you for participating in World IA Day Pittsburgh 2022.
Thank you for that introduction. Can everyone see and hear me all right? I'm going to take that as a yes. Thank you for responding. So as you mentioned, I work for BAMF Healthcare, which is a cancer clinic. Right now we're based in Grand Rapids, Michigan, but we will be expanding. We actually open in June or the end of June. And so there will be a little bit, I have questions I can answer about the specific clinic and then some that I'll have to wait till June to answer. But for the last year and a half, I've been working on a proprietary and custom electronic health record platform. This was a big endeavor, still working on it and still learning. But hopefully if you have any questions, I'll be able to answer them. What I'd like to do today is very practical. I would just like to share with you what I found helpful and what I didn't find helpful. I'm going to start with the entire audience because we always start there, correct? Patients are mothers, fathers, grandparents, children. We all have family and friends who have beat cancer and didn't. We'll be producing diagnostics and therapeutics for cancer and imaging for conditions such as Alzheimer's, Parkinson's, cardiac disease, and more. We use less radiation, so soon we'll be able to receive pediatric imaging referrals. And I just want to leave you with a number. In 2020, there was over 18 million cases of cancer. One thing I like to keep in mind as I'm designing for patients or for clinicians who are helping for patients is the emotional burden. They start off with being in pain, nausea, some appointments, but by the time they reach us, because we treat metastasized cancer, they are fearing for their lives and they're mentally exhausted. So everything I do, I try to make as simple and clear as possible. At one point in my career, I designed games and apps for children, and I often think back to those days when I'm designing for our patients. I just need a moment. I love this patient. She has cancer. She isn't going to make it, and she's younger than me. I always cry after I see her. This is from a clinician. She's an at-home occupational therapist, and this quote gets me every time. Our clinicians have to put on a brave front. The emotional and physical burnout is a real concern in this industry. When I interview our subject matter experts who are all clinicians, they've either worked a full day or they're in the middle of the shift and they're taking time out of their schedule to meet with me. They're amazing people. They wake up in the middle of the night to help patients arrange travel arrangements.
Miranda, we're not seeing your screen.
Well, let me go back then. So our target audience, I want you to see my beautiful handprints. Can you see now?
Yes.
Okay. Our patient's emotional journey, I'm just going to let you consume this for a minute, although you've already heard me talk about it. All of these factors of having a life-threatening disease add up at the end. So we go from pain, nausea, and appointments to drugs and side effects, financial stress, fear of death, and mental exhaustion. So again, I need to make this experience perfect for our patients because they're not thinking clearly and they don't have as much patience as they normally would. Read that quote. So the goals, fears, and challenges for our patients, caregivers, and clinicians overlap quite a bit. They're just coming from a different angle. Sometimes our clinicians can embrace technology, but others really struggle. They're often switching between 30 to 40 patients a day, or they're constantly interrupted. They're accustomed to antiquated technology, and it can be hard for them to see past those limitations when all of a sudden I'm coming in and asking them, in an ideal situation, what would you like? Some of the patient's goals here is to beat their cancer, but also manage their depression and pain, while the clinicians are focused on the patient's quality of life and helping their patient and their caregivers stay positive. The patient fears death and missing time with family, and clinicians fear losing a patient or not being able to provide quality care. The patient has the challenges of burnout, loss of dignity, poor aftercare, thinking clearly, and the clinicians are dealing with communication barriers, technology limitations, constant interruptions, and regulations and laws that can't always keep up. There's also blockers to care, such as insurance, financial concerns, proximity, and capacity. There's the additional challenges of electronic health records is it's a complex application. This is actually, as you see here, a real medical code. Everything is based on codes, but there's not one set of codes. And if any of you are in healthcare, you're probably laughing at this one. This is our favorite placeholder code to use because it's long. It's one of the longer ones, and because it mentions UFOs. And then healthcare is also just a challenge in general because there's fewer resources out there, fewer books, fewer publications, fewer experts to follow. I do want to say that I feel like this is changing quickly, and I'm very excited to see what's next. Language was a huge barrier for me. And by language, I do mean like I, as a software person, speak a different language than a medical person. The domain knowledge has been intense, especially because I could not even dissect a frog in high school. So I've had a lot to learn. Well, we've even dealt with things such as acronym overlap. To us, MDM means mobile device management, where to them, it means medical decision making. This is an actual image from a lunch and learn that we had, and I'm still not sure I understand it all. The solution to this gap was to be patient with each other, learn the basics of your subject matters experts, language, agree upon vocabulary and document it, and keep it up to date. And then a great book that I would recommend is How to Make Sense of Any Mess by Abby Covert. I also try not to say things like SEO and WCAG, but I often forget. And we're dedicated to keeping our Confluence page up to date. Another method of complexity is the backend architecture. The examples of good information can also be very hard to find. It's a challenge to stress test for edge cases because of patient privacy. You don't want access to your production environment. And then for clinical trials or artificial intelligence models, we need to de-identify the patient information before we can use it. When usability testing with patients, I have to constantly remind them to not enter real data because it's being recorded and that would be a violation. To reduce some errors around this complexity, I found it useful to work with one developer to create a plan for an epic or a solution, but then another developer will actually QA our work. You would expect to see perfect circles here. All of these blobs and very imperfect create your electronic health records from hospitals, patient reported symptoms, external labs, primary provider specialists, maybe devices. The reason why this isn't perfect is because it's an imperfect system. The hope is that all information will come in as expected, but it won't. It may not be quality or consistent. There will be a lot of information to weed through. My goal is to bring the right information forward at the wrong time for our subject matter experts. To do this, I've been working very closely with them. Just going to take a pause in my journey here to reflect on a survey that was done in 2019 of over 4,000 physicians. 64% felt like EHR added to their daily frustration. 38% spent time on the EHR at home and was moderately high or excessive. And 46%, the time they spent on their documentation was poor or marginal. So they're spending all this extra time at home to create good EHR documentation, and they still don't feel great about it. I'm going to say, like, we are the champions. I feel like UX has an incredible role to play in turning EHR around and the healthcare industry, in addition to the wonderful developers and engineers that we work with. I was incredibly nervous when starting this EHR. It was a big undertaking, but I'm happy to report that EHR benefits from the same tried and true UX process flows that we're accustomed to. Understanding the problem, analyzing, reflecting, building the solution, and then synthesizing and learn and repeat over and over again. I've done a limited competitive analysis that was very familiar to me. Feature task analysis, again, a tool that we're all familiar with. Multiple interviews with our subject matter experts and several collaborative sessions. We did a retro, just like the agile software teams use, and we're all familiar with those, hopefully. And out of that retro, the themes that came up were life-threatening errors, needing clean data, being able to visualize information pictorial when relevant, protecting patient privacy, and saving them time. A lot of this felt like to me was removing distractions so the clinicians could provide the quality care that they would like to. Usually when you work on a complex application, you have a lot of unstructured goals, really broad tasks, and trouble with product owners making decisions. I am lucky to say that our subject matter experts have very clear goals, and that's providing better care for our patients. I have to take a pause out here for those of you who may be listening only. This is a very dramatic image of an IV, and it says life-threatening UX. We've all heard those stories of bad UX resulting in catastrophic incidents. I've definitely had my moments of panic and pressure, making decisions and flows and processes that could result in a mistake for our clinicians. Some examples of the things that keep me up at night is creating good alerts when there's a contrast or medication allergy. Just using a standard alert is not good enough. Alert fatigue has also been studied. So metrics are very critical, and they need to come from a trusted source, which means probably not the patient, but a good quality lab. Emailing information to the wrong patient and violating HIPAA is a concern for our clinicians. Giving the wrong medication doses. And then visual noise overall was a large concern for me while creating this EHR. This is a fictitious example of what we did to co-design. This made our subject matter experts from basically relaxed, and this was easy for them to get in and create the system that they wanted. We're fortunate that they have very clear goals of what they want and they don't want, and basically the opportunity to focus on the patient and the data. And we did this several times actually in just slightly different methods. There's also additional studies available for what causes data inaccuracies. And then I'm going to give you some of the solutions that we came up for those. For simple miskeying was basically just miskeying information into a form because they fill out multiple forms throughout the day. We are providing structured forms. We're minimizing open fields, and we have a lot of checks. For example, the end date can't be before the start date. This does make our process longer, but overall, we're hoping it creates a better system. We're also repeating data in a pictorial form when useful. There's a lot of miscommunication that could come from the patient. To overcome this, we're going to connect to external EHRs, and then certain metrics may even need to be a phone call to their oncologist to confirm important data. To prevent wrong entry or lack of entering device data, we're working on connecting all devices to the operating system. That's a large and long-term goal. Delays in admission and discharge, we're going to use technology to schedule appropriately, to minimize surprises, and to leave room for emergencies. That was a big comment that they have said multiple times. Like, if there's an emergency, whether it's patient or equipment not working, there's no room in the schedule, and that just continues to compound throughout the day. The timeliness of the data entry, we're going to staff clinicians appropriately, and we're going to save clinicians time in other areas. And then whenever possible, we'll enter data without human interaction, so they don't need to focus on that. I've been able to remove a lot of unnecessary complexity that has been in past EHRs. For example, navigation. I saw numerous ways that they were providing navigation. And this was also a complaint I heard, is that there's so many ways to get to a piece of information that they ended up feeling lost on how they got there, and they couldn't remember that flow again. So we've reduced that. We've also reduced the types of navigation. I've looked at past EHRs and seen 4 or 5 different methods of navigation. We've simplified that to 1. The number of ways information is listed is also simplified. 90% of the time it will be chronologically, and the other 10 will be alphabetically. We only have 3 types of modals in our dialogues, and I'm going to keep it that way. And so far, fingers crossed, no modals. A really great article to read, and actually there's several articles and videos, is from Nielsen Norman Group on complex applications. We may only be able to do so much in the beginning to work around the complexity of the backend, but we're slowly going to make the changes that we can. We also introduced a discussion limit. So if a feature add-on takes us more than 5 minutes to discuss it, we decided we didn't need it for launch. And that's actually been very popular with our software engineers. Another tool that I used was service design. And if you haven't experienced this before, there are some really great talks out there that I can point you to if you reach out to me. Service design is incorporating the customer's journey with then all of the things that the customer will see, which is called front stage, all of the things that they won't see, which is called backstage, and the processes that support it. And then in red, I call out all of the information that I need, and it's critical, because if I can't get that information, that's probably going to slow the clinician down. And we did this throughout the entire process for June. So this is going to sound very, very uncomplex, which is good. But really what our clinicians were looking for was basically bringing the EHR up to today's basic UX accessibility and inclusion standards. A full disclaimer here, I actually tweaked our normal heuristics that we all abide by. I actually think healthcare might need its own set. This list is very obvious, but each one was real feedback from our clinicians. For example, for the visibility of system status, they usually can't tell when the software is loading, maybe due to slow or poor internet. And they're often in older buildings, and so poor Wi-Fi is a frequent problem. Matching between the system and the real world, I saw several labels where I asked them, like, how did the term chart come up when you're really talking about all of the patient's information? Well, it's a legacy name that just has never gone away. We're going to be providing customization and flexibility right away. And then as time goes on, we'll continue to tweak that ability to create their own solution and customize. But of course, we're going to be getting started with very good defaults. For consistency and standards, I work with an excellent design team, and they're using a design system right from the start. And they're almost done with it already, and we'll be launching in June. So I can't take credit for that. For error prevention and handling, I mentioned the 3 dialogues that we're using. We're looking at alerts and errors from a very holistic standpoint, and we keep working on it every time we start a new epic. Okay, are the guidelines that we created, do those still hold? Recognition versus recall, reducing tools. I know myself, I use 4 pieces of software every day, all day long, almost at the same time, constantly switching back and forth between them. A couple of them have the ability to create a table, and like the shortcuts are different in each one. I just haven't found the time to fix all those shortcuts. Aesthetic and minimal design. Again, I work with a great design team, and they're making, every day we talk about what can we remove, what can we minimize, what isn't clear. Stage disclosure has been very interesting on this project. And in some ways I'm lucky because our clinic has a very targeted focus. I'm able to focus on all cancer information first, and all other information is a click away. And then planning for interruptions. We know this is going to happen. And so one thing that we are doing is we're planning on it. We're going to help them pick up where they left off. We'll give them reminders for unfinished tasks. We know clinicians are in a complex environment, but our actual physical building will overcome that as much as possible. And then over time, as we're continuing to tweak what we came up with, the hope is that we're able to minimize those interruptions. A few other things they mentioned that don't necessarily ladder up to heuristics, but smooth rollouts when the software is updated and productivity metrics that don't feel negative. This is a device I use myself. It's Nervio by Theranostics. It's drug-free migraine pain relief. It's been approved by the FDA for migraines for over the age of 12. Most EHRs don't pay for the medical device database, so my neurologist has to order it by paper, the old school way. This device is incredible. It's definitely changed my life. It's very affordable because it utilizes an app on my phone for the most part. However, the biggest downside is it can't connect to my own EHR, either like what I can see personally or what my neurologist can see. I also can't allow my data to be combined on a larger scale. And I think that's really the next step that needs to happen in the healthcare industry, is allowing patients to be able to put their data in with everyone else's. And so we can really start to come up with some great solutions. Ooh, here we go. There we go. I feel like the future is here. This is what I hope what electronic health records will look like very soon. And maybe it already does, and I just haven't heard of it. With all of the other things that we're used to, hospitals, external labs, I hope soon that artificial intelligence is going to be part of our electronic health records, recommendations and predictions. I'd like to connect my wearables, like the device I just showed you. And then looking at genetics to treat patients as well, and really targeting that therapy towards them. I feel like being able to combine all of these things is really going to accelerate scientific discovery. Thank you. You can look me up on ADP list, or you can look me up on LinkedIn.
Thank you, Miranda. I know Celine was very charged every time you talk about these healthcare things. We have time for a few quick questions if anybody has any. Do you have any other thoughts to add now at the end? Now that it's out of you, Miranda, any other thoughts come to mind?
I would just like to encourage everyone to, if they see a healthcare job that they're interested in, to really consider taking it. I found it to be really rewarding. I'm very thankful for the opportunity that I have to work for BAMF Health. Every time I start a new epic or a new section, I'm actually very excited and, energized when I wake up in the morning. So, and if anyone had any questions or thoughts, feel free to reach out to me. I would also love, I know Pittsburgh, you mentioned, has a lot of healthcare UX professionals. I would love to connect. And I would love to, maybe start to chat right now about some of your experiences as well.
Do you think that you talked about healthcare needing its own heuristics. Do you feel that there's enough of writing about healthcare's unique UX stuff out there? I mean, I imagine much of it is proprietary, like companies are developing their own information and maybe they aren't sharing it as much.
I do think that's part of it. It's hard to be very specific, one, because you're protecting patient privacy, or it's proprietary, like you mentioned. There are a few people that I do follow, which I can post later, but it's not enough. Rosenfield Media actually, I think, has one book. Kate Swindler has a book about life and death UX that's really interesting. But yeah, there's not enough yet. But I do feel like there's more and more as I've been watching. My first healthcare project was 7 years ago. And at that time, I felt like there was nothing. And now every time I go and do a look to see if anyone's put anything out, I find something, which is really exciting.
I have 2 questions here so far that I want to squeeze in. First is, how did you get your start in healthcare UX?
So at the time, I actually worked for VML, and we were agency of record for Strykel Medical Group, which is actually, they have offices all over the United States, but they actually started in Portage, Michigan. And so they were, kind of stumbled onto it. But my first project, I was definitely hooked, and I had a goal of getting into healthcare full time.
Thank you. And then the next question that I have is, how hard is it to get feedback on your products when healthcare products are notoriously slow to launch to the actual consumers?
I think it can be hard, because like I mentioned too, there's that language barrier of, I have my language, they have theirs. And then the experts I'm working with, a lot of them are not in Michigan. It's another time zone, so there can be a lag. Some things that I have found the most helpful is that collaborative design. And so I feel like less feedback is needed because they had their say from the very beginning. And finding those tools where they feel comfortable giving you that input, and really having them come to the table. So really workshops gets people really comfortable. And I definitely felt like after I had someone come to one of my workshops, and I say come and they're virtual, I felt like they were that much more comfortable with giving me feedback.
Quick shout out to Jessica Knott, who's our next speaker of the day, also originally hails from Kalamazoo.
It's great. I am
very small connected world.
Yes, I think we know some of the same people even. So I'm very excited for her talk.
Okay, we have a question about what kind of portfolio elements do students need for getting into healthcare UX, and where can we see examples of your work?
So unfortunately, like examples of my work are completely locked because I've signed so many NDAs. I do have a site out there, but it's locked down. For portfolios, I actually want to encourage everyone to just look around. There's a lot of smaller healthcare companies that are starting up, and they're hiring UX designers right away. And if you talk to a company and they're not going to put you like at the table, just move on, because there are so many other opportunities. So as far as specific portfolio items, if you can't find a small healthcare client to work on, you could always take a healthcare solution that you've personally found yourself in and mock up what you would have done better.
Okay, this might be the last one that we have time for, but it's a good one. What's an example of an early surprise / misconception about your designs that you uncovered when talking to users?
So this is a good one. So I have found that each time I should remind people that I only do wireframes. This has happened to me a couple times throughout my career. I need to remind them that what I do is black and white. I actually use like a sketchy font, and my Figma files are even in these like kind of messy looking lines. Need to remind my subject matter experts every time that they are not going to see the final designs from me, because that does throw them it's thrown them a few times. I always mention, like, remember, this is the time where we want to collect all of your feedback. You can still make changes in the final designs, but this is the best time to give us that feedback of what you like and don't like. Also, another from previous question, if I don't hear people talking, I actually call them out in a meeting, and I say, John, do you have any feedback for me? And if they really are quiet, because there are some people that are really shy, I will even say, like, can you give me one positive and one constructive comment? So yeah.
Great practice in all industries. Thank you so much for your time, Miranda. Thank you so much for sharing all of this wonderful work and this wonderful kind of perspective and analysis of healthcare UX.
Thank you for having me.